position because he's so busy. Even when I met him at Kulia Petia doing so many lectures, supporting his peers and others. And I have seen there was a one discussions going on how to manage day-to-day pediatric patients, throwing so many questions, almost 1.5 hours to him. He has supported a lot to the doctors in Kuliapiti. So by that time he said, and I learned a lot. I want to pass all my knowledge to anyone who wants to get my support. So by that time I was requested him to sir, you have to start from Candy because that is the place where you were. I'm so proud because I'm also from his school, Dharmaraj College, and he was graduated from Dharmaraj College and practiced as a general practitioner for almost 13 years. Then he has qualified to become a consultant pediatrician after taking so many experiences in UK and came here and supporting to disseminate his knowledge with all his colleagues. So at the time that I have requested, he said, Hill Country Medical Association, Dr. Jayasekar and all the doctors are like my brothers and sisters. They are, so I'm always willing to share my knowledge. So that time I asked a question, of course, you will get more questions from the doctors throughout the career because they all know that you are going to support them. So without taking much time, I would like to invite our eminent speaker, Dr. Dilena Munasingha, to share his valuable thoughts on a very, very important topic that is unspoken epidemic of children. Over to you, sir.
Thank you, Gayan, for your kind words, and thank you very much for inviting me for this to speak to this gathering. And it's really, really an honor and it's a pleasure for me because to address this gathering because as Gayan mentioned before starting my postgraduate career, I have done almost 13 years of general practice work. So most of you all were my seniors and sort of gurus. I can see a lot of familiar faces, starting from Jayasekar Ayya to Chandrajayanta Ayya back. So, rather than taking much time, then we'll start topic straight away. So this is about very important and unspoken epidemic which we have recognized among pediatric community. So before going into this topic, I'll just go through few cases, few patients. We have seen, I would say, last 2 or 3 months time in our clinics and practice. This is the first case. He's 11 years old, obese boy with chronic recurrent abdominal pain, treated several occasions as gastritis, but there's no significant response to treatment. So when mother came in to the consultation, she said, Dr. Miyata digatam dina gastritis gatana beer gata hariyanne mane. So she was also preoccupied that this is gastritis. Then on questioning, we noticed that yes, he has abdominal pain, mostly morning time after getting up from bed. And sometimes it relieves with food. There's no real heartburn, regurgitation and all, but he has a bit of bloating sensation. And when I asked about relationship with toileting or pooing or opening bowel, he said, "Samahara velawat uncle toilet giyam bade ekak chuttak aduwe." So that is about one patient. So the next one, she's 13 years, referred to actually psychiatry ward for school refusion. So he has investigated or evaluated thoroughly, but ultimately he has been seen by 2 psychiatrists prior But ultimately, seen by one of our colleagues, he actually wanted to do pediatrics first. Then he decided to do psychiatry. And but they initially thought of social phobia and adjustment disorders, all those things. But his behavior, his problem, they couldn't fit into one definite psychiatric conditions. But then finally, what they did was they have taken a report or a letter from teacher. So the child's main problem was, I don't have friends at school. So that was his problem. Then teacher has discussed and gathered some information among his colleagues and noticed that nobody likes to stay with him because he's so smelly. Mostly when day goes on, usually at evening times. So basically nobody likes to play with him. Everybody's just going away from him. Then we raised that problem to mother, and then mother came out with the real problem. She said, yes, when he came in home in the evening, his underclothes are very smelly and he has a bit of stained stool and underwears. And some of the days, mother has thrown his underwears rather than washing because they are very smelly. That is about him. So, other one, 6 years old girl with chronic diarrhea. Not responded to several antibiotic courses she had initially. So it is when we inquired about diarrhea, we noticed that she was just passing little bit of watery stool about 8 to 9 times a day, sometimes without her sense. And stoolful report has done all the time it was normal, and they are given probiotics, antibiotics, but there's no response. And this girl came about 2 days back, 13 years old girl with recurrent urinary tract infections, but she had over last 13, 14 months about 7 urinary tract infections. Some were clinically like cystitis, but some were real urinary tract infection, febrile urinary tract infections. Investigations all were normal. These were 4 cases we had. So what did they have? They all had one common problem. They all were constipated. So it is going to be today's topic, the pediatric constipation. It is a real epidemic. It's a global epidemic, I would say. So it fits to the definition of epidemic in all aspects. When we take data, so it's globally, it is about the prevalence of pediatric constipation, or constipation among children is about 5 to 30%. The average will be about 9.5%. So if you starting from first world or West, USA and Europe, it will be 22 and 34% like. But even in South America and Nigeria, the numbers are same. So Asian numbers are around 12, but Sri Lanka, it is 15%. I knew this study has done only in 2012, about 14 years back, 12 years back. So we don't know current data on pediatric constipation. So when we say the percentages, the real weight, I would say, won't come into our brain. If I say every 1 out of 3 kids will have constipation, we will realize the weight of pediatric constipation. So it's a global epidemic. As I said initially, about 10, 12 years back, we thought it is a problem of first world or developed countries. Now it is not. It's a problem of everybody. And especially in developing countries, all the illnesses, especially pediatric illnesses, which were prevalent among Western countries, now we are encroaching or they are getting us. Right. Why we say this as unspoken problem? Actually, that unspoken nature also contributed to this increased prevalence of constipation. Unspoken because we don't like to talk about poo. Right? Nobody likes, and especially when the kids are grown up, when we ask about their toilet habits and pooing things, they are so reluctant, they don't come out with the proper answer. Right? Mostly when they come with multiple somatic complaints, we had to repeatedly ask about their pooing habits, bowel opening habits and all. And I am very much sure that all of you, including myself, none of us has asked from our kids, "Puta toilet එකට ගිහිල්ලාම කොහොමද ඔයාලට කක්ක ගියේ කියලා." We usually take it as sort of embarrassing question. That is why it has become an unspoken problem, right? So we all know what is the diagnosis of constipation. There are different variants of constipation diagnosis, but there's unique diagnostic criteria set by Rome 4 criteria guidelines. They had 1, 2, 3, 8. Out of that 8, if they have 2 or more, we can diagnose them as having constipation. So less than 3 bowel opening per week. So hard stools more than 25% of time. They had to strain. If they had to strain, sense of incomplete evacuation after opening bowel, sense of blockage, manual stress is usually it's not in our country as well because it's plus sometimes loose stools rarely present without laxative use because without a laxative use, if they have loose stools and no criteria to diagnose inflammatory bowel disease, this can be still constipation. That is because they do have what is called fecal soiling. Fecal soiling can present as the constipation can present as fecal soiling as well. We are going to discuss what is fecal soiling next. So this is the definition of constipation. In simpler version, if I say less than 3 times per week fits to constipation. So that is constipation. And one other definition, fecal impaction. What is fecal impaction? That is very important because most of our kids, they do present to us at the level of fecal impaction, not at the level of fecal constipation, because they do present late. So fecal impaction is when they have constipation and when it is ignored, the fecal load, which is loaded in a rectum, the normal body's mechanism is to absorb water from whatever the thing which is stuck in rectum. So what will happen is that when the feces is accumulated in rectum, the water absorbed and that stool will become stony in consistency. So then they can't pass that stool. Then it is called fecal impaction. So by definition, it is called retention of feces to the extent that spontaneous evacuation is unlikely. Right? But with that, they do pass a little bit of rapid poo like poo several times a day. And other thing is, when they have fecal impaction, what will happen is the newly formed feces, which comes from up, they are sort of liquidy. They go through that hard stools and come out from anus as watery stool. So they are very smelly. And other thing is when they have a lot of fecal impaction and the lower bowel has distended, so the integrity will be lost and they do get that soiling or passing of liquidy stool without their knowing. So that is called encopresis or fecal soiling. So that is a mechanism of fecal soiling. That is why they have taken fecal soiling as well as a diagnostic criteria for constipation. So when we talk, it seems it's very rare event, but we have seen a lot of kids with fecal soiling, the constipation kids presenting as fecal soiling. So this is again the mechanism of normal bowel and accumulated feces causing fecal impaction and fecal soiling. Right. Why you get constipation? So constipation can be a secondary problem due to some organic illness, like most common would be Hirschsprung disease and any neurological or neuromuscular, metabolic, and sometimes with drugs they use, and some psychiatric illnesses also can present as constipation, but it is very rare. The organic causes of constipation is around 5%, but most of the time, more than 95%, it is due to not due to an organic cause. It is called functional constipation. So functional constipation we do define as constipation that does not have an organic etiology. So our topic today is going to discuss about really functional constipation because it is common and it is treatable and it is preventable. So organic constipation, yes, there's an element of organic constipation, but it is rare. But by history and examination alone, we can most of the time we can notice or we can pick up organic constipation cases. Right. What are the consequences of constipation? So we all know, as we discussed on those four cases. So it is a problem of growing child. They like playing, they like activity, they want to do studies, but they do have chronic ongoing discomfort or pain. So it will affect all their domains. So it's really a physical disability, right? And emotional and psychological as well, due to pain and all the other problems which is related to constipation. Definitely it will affect their academic performance and social functioning. And they come with most of the time, these constipated kids will come with multiple somatic complaints to clinics, and we do go or misdirect on investigating on those multiple somatic complaints. As I said earlier, when we directly ask about bowel habits or history of constipation, they usually don't come out with constipation history directly. So we need to do sort of repeated questioning and repeated prompting to get that part out of their history. And bowel dysfunction, as I said, when they have fecal impaction and significantly distended bowel, and they do get what is called bowel dysfunction, and it will lead to fecal swelling as well, contributed to fecal swelling as well. Right. So what are the risk factors for constipation? So number one, toilet training, and number two, stool withholding, food and fluid, psychological stresses, and lack of physical activity. So I have bolded withholding because out of constipation cases, more than 85% of them had stool withholding behavior. So stool withholding is a major contributor for the development of constipation and for the progression of constipation into chronic constipation as well as fecal impaction. So withholding simply is when they want to go, they don't go. Then we call it stool withholding. Few words about stool training, potty training or toilet training. So toilet training is a big topic, although we don't have that activity that process in our scenario. It will be about 1 hour lecture, toilet training. So what I want to highlight one thing. So toilet training is we do have to train babies when they are ready to do their own what is called defecation practice. So usually they do get stool continent between 18 months to 24 months, that is 1.5 to 2 years. So at that time only we need to teach them on potty training. But unfortunately, not only in Sri Lanka, everywhere, what they do is when the kids are about 7-8 months, we put them on potties. So it won't create that sensible reflex mechanism and by that time they didn't develop that what is called the defecation reflex. So what will happen is when they grown up and when they grown up to the age of 18 months to 2 years, they do start doing fecal or holding because they didn't have that normal developmental process. So that is simply, and one more slide about potty training. When they really reach in the age to train on their potty, there are few aspects we need to know. So just putting on a commode won't create that straining as well as normal stool passage. So for that, they need to put on a potty, or if you are putting on a commode, we need to give them a support for their leg. So that straining starting from legs will create that normal physiological mechanism of this thing. And other thing is, rather than sitting with bending forward, and catching breath or holding breath won't create that normal passage of stool because the colon will be kinked. So for the colon to be straight, they had to follow what is called squatting posture. So I have just put this slide out of potty training practices because when we advise them, especially when we are on follow-up period after treating constipation, this is a good practice. We need to advise them on using potty. So they need to give some support for their feet as well as the back has to be straight to have that normal physiological flow of feces. Right. That is just a few words about potty training. And withholding, as we said, withholding is a major contributor for constipation. So causes for withholding, yes, as I said, poor toilet training, or I would say premature toilet training would cause stool withholding, and any illness or unwellness. So the babies, then they would not like to go to toilet. Then they will start with holding poo. That will start the cascade of constipation after holding this thing. And travel, we all know, kids, they are all potty or they are familiar environment to defecate or pass stools. So we have seen a lot of some parents when they are travel, where they take their kids potty as well in the boot of their vehicle. So it's a very good practice because travel and change of environment, change in environment and diet as well. So when they have diet which is contributed to constipation, to develop hard stool, and when the passage of stool is difficult, they start the process of stool withholding. Then what will happen is it will develop into this vicious cycle. When they withhold stool, the stool will build up in the colon and it get dried due to water absorption from that. Then the passage of stool will be painful, then be constipated. So constipation again can carry on this vicious cycle of withholding, building up stool, and painful defecation. So when we are treating, so we need to discuss as well as we need to inquire about these withholding behaviors, and we have to break that chain from some feasible place. And two more slides about common practices in our setup which can lead to stool withholding. This is number one. This is common scenario and normal scenario in most of our households. When the kids are going to school, we do dress them nicely, then we feed them and send to school, try to send to school. But that's what is called for normal bowel opening mechanisms or mechanism or the defecation mechanism. That's what is called gastrocolic reflex. So when the stomach is full, they do develop sort of desire to open bowel. It is starting from upstairs. Within about 30 minutes after the stomach is filled up with food. So in this case, what will happen is, by the time she wanted to go to toilet, she's on a school van. Or other thing is, even if she develops desire at this moment, she's dressed, nicely dressed, and intentionally or subconsciously, she will start withholding. So when I do practice advise parents on constipation, I do practice this cascade. Glass of water in the morning, feed after 5 to 10 minutes, 30 minutes after, let them stay in the potty. After that, rest and send. Although sometimes they might not open bowel, but when we start practicing this become a reflex, and it will help to get rid of this stool withholding most of the time when they have. And other aspect is, when they go to school, what will happen? The expected toilet should be like this. I have taken this image. This is one of the this is the toilet complex of one of the leading boys' schools in Kandy. But unfortunately, more than 99%, I would say 100% of the time, the toilet would be like this. None of us or none of kids would like to open their bubble, go to this kind of a toilet unless they do have a gastroenteritis and diarrhea. So, right, that is about stool withholding. Diet, I don't think I need to talk about diet, which is in relation to constipation. We all know junk foods, cola, biscuits, and especially the rusks. When kids are, especially infants, when parents start weaning, the first thing most of them would bring is rusk, namely Pali's rusk, right? So during our wardens, we have seen a lot of bedside cupboards, a packet of rusks. So this rusk would absorb a lot of water. If you ask parents to put that rusk into a glass of water, the half of the glass water in the glass would absorb into that rusk. So it will be a leading point to develop constipation. So that is about diet. But before that, there were two other contributing factors for constipation. These factors, I said, psychological stresses and lack of physical activity. So researchers has clearly proven that psychological stresses has an impact on development of constipation, stool withholding, as well as directly to the constipation, household disharmony, and undue pressure, undue academic pressure, everything has contributed to stool withholding and constipation. And there was an ongoing research, it has not yet published, among grade 5 scholarship students. The constipation is significantly high among them. So their numbers were about 35 to 40%, they say. So, but it has not published yet. And lack of physical activity, it has proven that physical activity has direct relationship with bowel motions, bowel movements of the lower bowel. So sedentary life and limited physical activity has significant relationship with development of constipation. Right, that is constipation. And how we evaluate. As you know, history is the most important part. So we need to ask about frequency, pain, straining while passing stool, bleeding, soiling or incontinence. I would say again and again, soiling and incontinence, you need to ask about 5-6 times until they come out with correct answer. They won't say, especially parents, නෑ ඩොක්ටර් එහෙම මොකුත් වෙන්නේ නෑ. ඊට පස්සේ අහුවාම මේ යට ඇඳුම් වලින් පොඩ්ඩක් චුට්ටක් ඉතින් ගෑවිලා තියෙනවා ඔය මේ එහෙම තමයි. Right? It's very common. And other thing, poor appetite and abdominal pain, that most of the time improves with passage of large stool. So, and that is very important clue for the constipation in a child with abdominal symptoms and abdominal pain. And stool consistency. So this is again, if you ask about stool consistency, normal. So then I would say you need to show it distal stool chart, right? If chart is more above type 3, it is constipated stool, right? I would advise you will have this in your practice, as well as you can download and show them. මේකෙන් කොයි වගේද යන්නේ? normal තමයි යන්නේ. මේකෙන් කොයි වගේද යන්නේ කියලා පොඩක් කියලාට පෙන්නන්නේ 2 to 3. So if you are sure this is going to be a constipation case, if you show, they'll say 2 to 3. So you can Google it and get it. There are a lot of nice images of Bristol stool chart. There are some calendars as well from some of the pharmaceutical companies. So it's better to have a Bristol chart in our practice. And other thing is retentive posturing. So when they have constipation and fecal impaction, the child would do what is called retentive posturing to prevent passage of stool. So this is not a dance. This is what retentive posturing. They do cross knees and bend or hold to some object. Mostly they don't hold to a wall also. They just hold on their parents' clothes when they want to pass stool, and they hold it. So those things in our history we need to ask. Right, examination, we need to do full examination including growth parameters, because the constipation per se won't cause failure to thrive, but most of the time significant failure to thrive will give us a clue this constipation can be due to organic, but it is not functional constipation. No PR, please. Right? You can do perineal examination to check the anal positioning and any abnormalities of the anus or any wounds, any anal fissures, but not to do PR for the diagnosis of constipation. So that PR would be a traumatic experience. Sometimes non-constipated child will start constipation from that point onward. So therefore, it is not advised to do PR. Full abdominal examination. Most of the time, when they have built up stool, they do have fecal masses. The fecal masses would have in left iliac fossa, and it is painful. So there's no other cause to have a left iliac fossa pain unless it is an ectopic. So it's basically gives us a clue to constipation on abdominal examination, and spinal and abdominal examination and neurological examination of lower lip also important to rule out any organic causes of constipation. Right, next we do investigations. Do we have to do investigations to diagnose constipation? I would say no. So there's a common practice to thyroid functions in constipated child. It should not, because hypothyroidism, the percentage of constipation on hypothyroid children will be only 15%. So if the child is clinically, unless the child is clinically hypothyroid, we don't have to do thyroid functions. And celiac serology and allergic testing, they do in Western countries, because Western countries, the celiac disease is very common and they do have a lot of cow's milk protein allergies and all. They do those investigations, but in our settings, not. X-ray, not. We don't have to do X-ray for the diagnosis of constipation. The history and examination would be enough. But sometimes we do X-rays in constipated children. Number one, in resistant constipation cases, because if they are not responding to treatment, sometimes by doing X-ray, we can see the level of fecal impaction. And other thing is, when we do what is called fecal disinfection regime, sometimes with that, if they don't get improved, to check the compliance, we can do abdominal X-ray, but it is not a routine practice. So in summary, no routine investigations for constipation. Right. Next, how I'm going to manage. This is the management paradigm of constipation. So number one, we need to make sure there's no red flag signs to direct us to a organic constipation. So what are the red flag signs? So constipation from birth gives us a clue whether this is Hirschsprung disease, or basically Hirschsprung is the commonest one. And delayed passage in meconium during first 48 hours. Usually within first 48 hours, the baby should pass open bowel. But if it is delayed or constipation since birth, if it is constipation since birth or first week, it gives an indication or clue for the diagnosis of Hirschsprung disease, especially in breastfed babies in our setup. But formula-fed babies, they can have constipation in first couple of weeks as well due to cow's milk protein intolerance or allergy. But in our settings, no. So abdominal distension and vomiting, which give, so it is obstruction. Ribbon type stool pattern always. So when they have, it is one of very rare entity, the anal stenosis. When they have anal stenosis, they do have ribbon type stool always, but it is not alternating. But in constipation children, they can sometimes have ribbon or rabbit poo type stools, but it is alternating with normal or watery. So neurological deficiencies like leg weakness and abnormal position or appearance of anus, spine problems, and growth faltering and developmental delay, they are red flag signs. We need to look for those red flag signs when we do evaluate for constipation. And next important management step would be explain the situation. So this is constipation, nothing else. And what are we going to do? Mostly for impacted constipation and impacted child, we need to treat for about 3 to 6 months. We need to tell them, because otherwise they won't comply with the treatment, and we will possibly lose the patient. Number one. Other one is because ඒ ඩොක්ටර් එකෙන් ගත්ත ගන්නකොට නම් හොඳ වුණා මාස 2ක් විතර හොඳ වුණා ඊට පස්සේ ආයෙ එන්න ගත්තා ඒක හරියන්නේ නැහැ. Right, ඒකනේ common. We need to explain this is constipation. You need to treat at least minimum මාස 3ක්වත් මේකට බෙහෙත් කරලා තමයි ගොඩ දාගන්න පුළුවන් කියන එක clearly කියන්න ඕනේ. Next, medication, behavior and body training, and diet. So I have put medication as third because most of the time when we do discuss medical problems, management problems, we do keep medication as last, but taking behavioral and other things like hypertension or dyslipidemia or diabetic management, we would take medication to the top of the list. But here, medication should come top because we need to medically disimpact if the child is impacted. Otherwise, nothing will help. So behavior, few behavioral principles, regular meal time for regular potty time. So if the meal time is irregular, that gastrocolic reflex will not come regularly, then the biological clock will get violated or this thing, and establish a routine. And other good practice is when some of them, when they start constipating, one good practice is to advise toilet after each meal. Sit down for about 2 to 5 minutes or 3 to 5 minutes after each meal for them to develop that gastrocolic reflex. And this is one of the toilet training principles they do practice babies around 18 to 24 months. And proper toilet positioning and seating I have discussed, and don't ignore the urge. If you want to go, go. But in our setup, school right. Avoid holding breath and bending forward, I have discussed, and regular exercise, stress management, and positive reinforcement. When they have constipation, then we start managing, and sometimes when they have this fecal soiling and all, so not to punish, but to positively reinforce them for good days. Fecal soiling soil smelly not to do anything negatively. So that is called positive reinforcement. Next, diet. So I don't think we need to talk about diet. So we know what are the good and bad things in diet, but two things, water for wind and adequate fiber. So most of us do advise them to have plenty of water. What will happen is they drink a lot, they will plus a lot of urine. Nothing will happen for their fecal formation. And fiber as well, studies has proven increased amount of fiber won't help, but they need to take adequate fiber only. So adequate fiber and adequate fluid is important. Next, medical management. So this is very important. Dietary and behavioral interventions along as first-line treatment will not help in managing constipation. You need to manage medically. So how you manage constipation medically? So two components. If they have evidence of impaction, we need to disimpact them. Then we need to start maintenance treatment for constipation. So disimpaction is flushing out, in simple words. So that has to be tell to the parents. මේ බෙහෙත් වලින් ඔක්කොම ටික ෆ්ලෂ් කරලා යවලා තමයි මේ ලෙඩේ හොඳ කරන්න වෙන්නේ. නැත්තම් නම් බෑ කියන එක කියන්නේ. So what are the drugs we do have for disimpaction and maintenance? So there are two types of laxatives, osmotic laxatives and stimulant laxatives. So earlier setup, we do had stimulant laxatives top because most of the time when they have constipation, Dalplux. So now Dalplux has come down in the list, Bisopodil. The first one would be PEG, it is called polyethylene glycol. It should be the first line, and it is very effective. More than 80% of constipation can be managed along with polyethylene glycol. We know what is polyethylene glycol, molecule, right? And next one is lactulose and magnesium sulfate. Sodium deposit is not available in our country, and as stimulant laxatives, sulfate and senna both not available in our setup. We do have only bisoprolol. So easiest and best and inert drug would be PEG, polyethylene glycol. It is freely available. One thing, we don't have pediatric Movicol here. So we do have several preparations, Movicol, Colimov, and Casenlax, right? But none of them are pediatric. But it is just a molecular size only, so we can give that. We can prescribe adult polyethylene glycol in half of the adult dose, half of the recommended pediatric dose, in half of the recommended pediatric dose. So stepwise, initially we do treat with polyethylene glycol, failing which we can add stimulant laxative like Dalcolax or Bisphodil. If not, we can alternate it, substitute that stimulant with a different one or a osmotic laxative. I do practice. I do give two osmotic laxatives, PEG and lactulose both. It's very effective, 100% success. So that is for disinfection. So disinfection, we need to tell parents as well, we give large doses, in large doses to flush it out, right? What will happen if we give inadequate doses of osmotic laxative to an impacted child? The feces, which has formed top, would get bit liquefied and it will pass through anus as fecal soiling. The kids who didn't have soiling will develop soiling, and kids who has soiling will get aggravation of soiling. So then they will lose faith on our treatment and we lose patient, right? Get rid of that. Tell them that we are going to treat you with this medication. This is not normal routine dose. I am going to give you double or triple dose of this PEG. So once the child is properly disinfected, the child should pass about 2 to 3 types of clear watery stool. Then only we know everything has passed and totally disinfected. We can now go to the level of stage of maintenance. So until that time, we need to increase what we call dose, which I am going to discuss next. So we need to tell them that bowel will be busy during disinfection. So what I would advise is, if they are really disinfected and if they have fecal soiling, and if parents are sort of not really cooperative and trustworthy, I would rather admit them for about 1 or 2 days for the disinfection, because when we give large doses of Movicol, they will have about 5-6 times of large amount of stool, and usually they don't get a lot of abdominal pain but discomfort. But the stimulant laxatives, Dalcolax, they do have abdominal pain because Dalcolax will push down. This thing would cause only the stool consistency will be liquefied. So they will get a bit of pain, but unreliable and untrustworthy parents, I would rather admit for disinfection. Otherwise, if we can be sure about this thing, we can give even as OPD basis in the sense they can give at home. And other thing is, when they lose a lot of feces, there's a theoretical risk of electrolyte imbalance, but some PEG molecule preparations has electrolyte on it. So we can give those preparations, or else we can dissolve that polyethylene glycol sachet in Jeevani. Then we do provide electrolyte as well. So when we are giving PEG, it comes as a powder, as a sachet. So when we are giving that sachet, we can dissolve it into water, or else we can dissolve it in a drink and keep in the fridge and keep. So how you get or how you remember this disinfection regime? It is very easy. This is what I do. I do Google ERIC disinfection regime. This is parent education website, UK based. So then there's what is called a parent's guide to disinfection. If you click parent's guide to disinfection, this would come. And there's a PDF downloadable version of disinfection. It gives a very clear instructions when to give, how to give, when to increase the dose, and what they would expect. And all. So I would rather advise you to keep one of these PDF printouts with you. Then, so for the English speaking people, understanding people, you can give that straight away, or else we can tell them. So it's a very clear, simpler version of disinfection. So when to start, how to give, how to prepare a polyethylene glycol, and what to do if the child is not taking. So it's simple. Google ERIC disinfection regime or Movicol disinfection regime, and you can download it. And this ERIC website, it's a very helpful website. It is parent education help website, which gives not only constipation guidelines, some other instructions as well. So this is the standard disinfection regime. I don't think we need to remember this because I have just copied from ERIC website. So let's child under 1 year, you can give half to 1 sachet per day. But this is, mind you, this is pediatric Movicol regime. So if we are giving the adult version of Movicol, what is available in our country, we have to give half of this dose. So usually what is recommended in our setup is not to give Movicol less than 1 year. After 1 year, we can start. So after 1 year, half to 1. That means per day, they can have 1 sachet, right? Or so 1 sachet of pediatric, then in adult one, we can give half of that sachet. So 1 sachet has to be dissolved in 250 ml of water or drink. So it's there in ERIC disinfection drink. It's very easy. So you can give that. Failing which, so what we do is, from day one, we are increasing the number of sachets, right? So starting, if you see 1 to 5 years, starting from 2 sachets per day, 4, 4, 6, 6, 8, 8. So we can give 8 sachets per day. So it's about 3 or 4 times of adult dose of Movicol. But this is to disinfect, and it won't absorb in the system. We need to tell parents, you're giving a large amount of drug, large volume of drug, but don't worry, this won't absorb, and this will clear up your kid's bowel. So once we disinfected, then we'll have to start what is called maintenance treatment. Or if the child is not impacted, we can straight away start constipation management or constipation maintenance management. Usually the maintenance management is about half the disinfection dose. So if you had to give 2, sometimes we can give 2 drugs, or we can manage it even a single drug. So it has to continue several weeks after regular bowel habits established, and we need to wean it off over 3 to 6 months. Otherwise, it will rebound and we lose the patient. So therefore, the close follow-up is very important to prevent this. So this is maintenance dose of PEG. Right. That is constipation management. Any questions? Any questions? Any other practices we will practice, which I can learn from you? Yes. So I have intentionally omitted that. In constipation management, colorectal medication is also has a place, but in pediatric constipation management, as I said earlier, we should try not to use as much as possible. If after about 3 laxatives, if child is not opening bowel, we can try colorectal preparation, right? So 1 laxative, 2, 3, failing which we might think of giving enema or PR preparation. Failing which, we have to go for manual evacuation. Right? Mind you, that increased dose of Novicol will do it. So we don't have to go for manual evacuation or PR, because the problem of rectal is that it is a traumatic event. It will start fecal withholding afterwards. So nobody likes anything. But if there's no option, some babies, some kids, especially these children with developmental problem and autism children, they don't like to drink a large volume of fluid. Then we'll have to go for this thing. But there as well, if they reluctant to take orally, the best option would be to give NG rather than PR. NG Movicol first, failing which we can go for PR.
If hard stool at the anus and rectum,
Yes.
will it get inside the
Yes, Movicol. Sometimes so although